We'll move on to our next speaker, Dr. Ramesh Agawalla. Dr. Agrawalla is going to speak on recent innovations in abdominal wall hernia repair.
So, good afternoon to post-lunch session. We've had very interesting talks. I would like to thank the organizing committee of IASGCON to give me this privilege to give this talk, Recent Innovations in Abdominal Hernia. So surgery for hernia has evolved as a separate specialty. So when we were house surgeons, hernia was never considered as a specialty. Hernias were left to house surgeons and postgraduates, but now it's a different ball game. Now we have a better understanding of the functional anatomy and dynamics of the abdominal wall. And abdominal wall hernia is not about only covering the hole, but you also have to maintain the function of the abdominal wall. So we are all aware about this classification. It's very important that you are aware, and whenever you see a hernia, you should classify the hernia. And you can do it if in midline hernias, M1 to M5, depending on their distance from xiphisternum, umbilicus, or symphysis pubis. And lateral incisional hernias, you have these 4 zones which are depicted in the picture, L1 to L4. So, and we need to have the size of the defect. Can I have a pointer? So we need to have a size defect because we need to know the size of the mesh we are going to use. So if you have a solitary defect, it's okay, but when you have multiple defects, then you have to take the... So you have to take the uppermost margin and the lowermost margin and the most lateral margins to determine what is the size of the defect, and accordingly plan your mesh size. So it is very important that you should classify your hernias, whether there is M or L, and you should also have the width of the hernia, W1, W2, W3. So when you do, then you can sort of compare the results of different types of repairs in particular hernias. So we are very well aware in our postgraduate days or when we were in college, if you had a small umbilical or a parambilical hernia, you would do a Mayo's repair or a tissue repair. And if you have the small incisional hernia, we would do a Keel's repair, where the sac would be pushed in without opening it and the edges would be closed with sutures. Then we had this mesh which came in, and now we can't think about any hernia repair without a mesh. The mesh can be laid in different positions, as you can see. So you can have an onlay, you can have a sublay, you can have an underlay, or you can have an inlay. So you can put the mesh in different positions. Now, with the advent of laparoscopic surgery, when in 1987, when the first cholecystectomy was done, after that, we have started trying to do everything laparoscopically, and then there was the advent of IPOM, intraperitoneal onlay mesh repair, where you reduce the contents of the hernia and you put appropriate size dual mesh by a fixation method, dual fixation by tackers and by transfixation sutures. But here, this is basically a bridging repair. So here, you're not restoring the linea alba, you're not augmenting the abdominal wall. So then we switched on to IPOM plus, where we would close the defect and then put in the mesh. So here we were restoring the linea alba and augmenting the anti-abdominal wall. But as all surgeons, we are so egoistic, so we have cases of obstructed or irreducible hernias, and we continue to do it. So in that cases, suppose you had a irreducible hernia, so you can do a hybrid repair. If you're unable to continue with the irreducible repair, you can make an incision, dissect the sac, and reduce the contents, deal with the sac, close the sac, and then carry on with the IPOM. So this is also a possibility of doing a hybrid repair. Now, all these meshes which we're using for these small midline hernias, umbilical or parambilical hernias, were very expensive. And for that, this scola came. In this scola, you're dissecting in the subcutaneous plane and putting a polypropylene mesh. So you're cutting on the cost. So this this method it's just like an onlay repair, but which is done laparoscopically, and you can also deal with divarication in these cases. Now, this ETEP-RS, this was basically by George Dias in 2012 for inguinal hernias, where to create a larger space for complicated hernias and inguinal hernias, and then it was extended to ventral hernia, and this became ETEP-RS. But this could be for a particular size of a defect, but very large defects would require some sort of a release. So in ETEP-RS, depending on where your hernia is, you can start from the left side, you cross over to the right side, and you can develop the plane down and then place the mesh in the recto-rectus space. And this is how it would look like. So after you've done the dissection, you can put the recto-rectus space, and this way it would be a sublay. So now we are moving from the intraperitoneal mesh to sublay position of the mesh. Now, one of our own colleagues, Ashwin Masurkar, came up with this surgical innovation of TARM, which was published in World Journal of Surgery. And here, what he looked at, that in ETEP-RS, you were going below the rectus sheath, below the rectus muscle endoscopically. Here, he was approaching through the through the peritoneal cavity. So it was just like doing a TAPP. So as we do TAPP in inguinal hernias, this was being done in case of abdominal hernias. So he had this 3-port TARM and 6-port TARM. So if you had a lower abdominal hernia, so these were his port positions, and then he would create these flaps and then put in a mesh. And this is how it would look like. And if you had a central abdominal hernia, then you would have to have a 6-port TARM, in which you would have an upper flap and a lower flap, create the plane, put the mesh, and then close the flap. So this was this. Now, we couldn't deal with all the hernias, so if they were very large hernias, you needed some sort of component separation. So there was this anterior component separation, where you, in this open method, you did externalizes, and then you raised the flap and came to beyond the linea semilaris, and then you divide the external oblique. And once you divide the external oblique, you create a plane between the external oblique and internal oblique, and then you can medialize and close. So get a possible medialization about 20 to 25 centimeters as the umbilicus, but the disadvantage was that there would be flap necrosis. So as you can see, this vascular supply would jeopardize, and this would lead to flap necrosis. So then we went to endoscopic component separation. So in endoscopic component separation, there was no need to raise the flaps, so there was no question of skin necrosis, but the medialization was limited only to 8 to 10 centimeters. And this was not possible for odd-site hernias. So then, after anterior component separation, we had this posterior component separation. But in posterior component separation, when you extend the Reeve Stopa plane and go in between, you would damage the nerves, and then there would be weakness of the lateral abdominal walls. So Professor Yuri Novitsky published this paper in 2012, where he talked about posterior component separation, which is the TAR technique. So in this, what he's doing is making incision on the posterior rectus sheath and developing a plane behind the rectus, and then you come to these vessels. These vessels you can see, which are there near the linea semilaris, and then you divide the transverses and get into the plane between the transverses and the fascia transversalis. So you can go laterally up to the psoas muscle, below you can go up to the Cooper's ligament, above you can go up to the central tendon of diaphragm. And then you can close the posterior fascia, put a mesh, and then you can do anterior closure and close the skin. So this is possible for very large hernias. It is basically an extension of the retromuscular Reeve Stopa repair, increases the abdominal cavity by 30%, significant posterior rectus sheath fascia advancement, and wide lateral dissection, preservation of neurovascular supply, avoids subcutaneous tissue undermining. But there are certain controversy, limitations. It's applicable to midline defects, extensive dissection into lateral planes of the abdominal walls, hence more traumatic. It's a very traumatic surgery. You're sacrificing an entire musculofacial layer. And there are seromas and superficial wound infections, and there's also a certain amount of recurrence. So then we had this peritoneal flap hernioplasty, which was again a modification of Rife-Stoppa's retromuscular repair. And here what you're doing is you're using the hernial sac for the repair. So you make an incision on the rectus sheath, and this becomes a flap. So this becomes your posterior flap, and you make an incision here in the rectus sheath, and this becomes your anterior flap. And you can put, you're closing the flaps here, and you're closing the flap here, and you can put the mesh here. But basically this is a bridging repair. But here you don't have to cut any muscles, and you don't have to do any extensive lateral dissection. It's less traumatic, and the only limitation is that's a bridging repair. But this paper was published by Dr. Andrew, and they showed very good results by this technique. And they summarized that it's an excellent and a versatile method for reconstruction of large ventral hernias, both in midline and transverse incisions. And they felt that there was no need for doing a TAR technique. But we also come across hernias which have a loss of domain. So there are a lot of big hernias where you have these huge bulges, and most of the contents are outside the abdominal cavity, and there is no standard definition of loss of domain. So when you see it, you know it. And there is more of abdominal viscera outside of the abdominal cavity than inside. And there are different methods of finding out how much volume is there. This is Tanaka method and the Sprague method. So what happens is, if you're dealing with these hernias and if you try to push the contents inside, there's going to be a compartment syndrome, and the patient will be on ventilator, and you may lose the patient. So you need to increase the size of the abdominal cavity, and you can use Botox, which is a neurotoxin, which will paralyze the muscle and elongate the muscle and reduce the defect and increase the cavity. And this can be used for defects more than 10 centimeters, and this can be used in conjunction with PPP. So how do you do this? You use about 100 to 500. These are expensive. Botox is expensive, so depending on what you're looking at, how big the hernia is, you can use 100 to 500, and it's 4 to 6 weeks prior to surgery. And usually if you do it with the help of your radiologist, it helps to identify the muscles, the 3 muscles which you need to infiltrate: external oblique, internal oblique, and transverses. So preoperative progressive pneumoperitoneum, you can combine this with Botox to widen the abdominal cavity. So what you do in this, you put in a catheter and then insufflate the peritoneal cavity. You start with 200 to 300 cc of air, and then gradually increase. And you can introduce up to 1 to 1.5 liters daily. And gradually the abdominal cavity increases. So you can use both preoperative progressive pneumoperitoneum together with Botox, which would help in such large hernias where there is loss of domain. So you can see you have a lot of options. You have peritoneal flap, you have IPOM with or without component separation, IPOM plus with or without component separation, anterior component separation, which can be endoscopic open, posterior component separation with TAR, which again could be endoscopic open, and Botox and PPP in large hernias. So basically what you need is you need a balanced approach. You have to see and study the patient as a whole. You have to see the BMI of the patient, the age, the comorbid factors, the anesthetic risk factors, and the type of hernias, and they take a conscious decision where your patient is safe and you can deliver good results, which is very important. So it can't be you have one solution to all hernias. You have to tailor the solutions to the hernias. Thank you very much. I would take this opportunity to invite you to the World Congress of Endoscopic Surgeries, which is happening for the first time in India in city of Calcutta in 2024. It's going to be held in the month of October in 2024. And this is an opportunity to showcase Indian surgery, and all the associations are involved in this. And the registrations has already started. You can go to the website and register. And if you have any more questions about the World Congress also, you can get in touch with me. Thank you.
House is open for discussion. Any questions?
Thank you.
Thank you, sir.